For this next session, what we're going to do is we have 4 panelists, and they're going to have 7 or 8 minutes to give their take on these questions, and then we will have a discussion, and hopefully the panelists will interact with each other. And I'm sure they'll have comments on each other, and then we'll open it out to the audience. So we're going to start with Paul Spatanik, from Chief Actuary from Medicare and Medicaid Services.
Thanks, Louise. Thanks for having me. It is really a challenge to follow such a group of distinguished economists, especially for an actuary, a humble actuary. Basically, every note I have already written has already been said in one degree or another, so I'm going to try to frame it in a little different way and hopefully just introduce a little different take on some of these topics. As has been mentioned, looking at Medicare payment policy, fee-for-service payment rates are based on non-physician, most non-physician payment rates have been are updated by the underlying cost index of providing those services, less this economy-wide non-farm private business multi-factor productivity adjustment. And the question that's been raised ever since this has been adopted in the Affordable Care Act is, does this call into question the long-term adequacy of those payment rates for the Medicare program? What are the implications of those payment rates? So the key part of the fee-for-service rates is that these are not quality adjusted. These are basically on a fee-for-service basis. So the more units that are provided, the more revenue generally that's provided to the providers. Some services and some demonstrations might have some quality component to them. They might build some tilt into the amounts of the revenue. But largely speaking, the fee-for-service program is more units provided, the higher the revenue that goes to providers. Some examples, penalties for readmissions is an example of a recent policy that kind of does put more of a quality piece to it. But generally, we're talking about the tilt. And so the fee-for-service incentives truly are to provide more services. That's the underlying, that is what will lead to additional revenue for these providers. And so most of the incentives in this fee-for-service program tend to be not directly related to am I providing better care, am I providing more care? And the question that I continually struggle with, and I'm looking forward to hearing responses from the economists on the panel and otherwise, is that if providers can be productive, and then I think the evidence that we've seen is very compelling in terms of are we getting value out of what I'll call the lack of unadjusted productivity? Are we getting value there? And I think the answer is yes. We're getting better outcomes. We're getting on this quality adjusted basis. But if these providers can provide productivity on that basis, how come they're not as good or so good or good at all or even positive with respect to how their revenues are actually being generated? Why are they not able to actually maximize their revenue or use this productivity as a means by which to maximize their revenue? So I'm looking forward to see Louise writing, so I'm looking forward to hearing the answer in a little while. So just in terms of just general data, over the last 10 years where we've had very low economy-wide productivity has averaged about 0.5%. Most health providers have averaged between 0 or 0.5%. So a relatively small gap over the last decade. During this last decade, we've seen a significant divergence between Medicare payment rates and private payment rates. I know we're not allowed to talk about, or cost shifting doesn't happen in this room, and so there's a lot of different terms for it, but I see a wedge. And whatever it is, the wedge has gotten worse since there's been at least some degree of clamping down on the Medicare payment rates. Looking towards the long run, and trustees, the Medicare Board of Trustees look at the long run. Many people do 75-year cost projections. The expectation for the long run economy-wide productivity is 1%. The expectation was illustrated earlier is 0.4% within the health sector. 0.6% adds up a lot over 75 years. In fact, if you were to account for that, roughly that 0.6% difference, the Medicare report does an illustrative alternative scenario where, what if we assume the productivity payment reductions weren't at the 1% level, but at the 0.4% level, and a couple of other different pieces. It adds up a lot. Under current law, the expectation is that Medicare payments at the end of the 75 years would get to 6.5% of GDP. Under the illustrative alternative, where just that 0.6% is changed, and a couple other factors, the difference is 9%. So it is a huge impact, especially looking over the longer term. We look at margins, and yes, this has gotten a lot of attention. It's been alluded to earlier. Medicare margins have been bad and are getting worse. Since 2010, hospital margins have fallen from, on average, minus 5%, is now closer to minus 10%. And this is at the same time when hospital margins for non-Medicare on the private side, they're at all-time highs. Again, not talking cost shifting, whatever the current term is, there's something happening here where there are shifts occurring. The question becomes, what happens in the long run with respect to these payment rates, especially when the economy-wide productivity actually comes back from these historic low levels of the recent decade, and when these productivity adjustments will actually start taking a bite within the Medicare program. So with that, I'll turn it over.
All right. Thank you. Let us turn to Jim Matthews from MedPAC. Yep.
Good. All right, great. Thank you. Sorry about the technological glitch there. So I'm going to take a little bit of a different tack here with a couple of comments here and shift the discussion a little bit from productivity to efficiency in the hospital sector, which is a policy aspect that the Commission has been dealing with not only in the hospital sector over the last 6, 7, 8 years or so, but also starting to apply this concept in our evaluation of the adequacy of Medicare payments across a number of different provider types. And here I'm going to be talking about a combination of relatively high quality and relatively low cost, which does implicate the concept of productivity and especially change over time, but I'm going to be talking about a very specific aspect of productivity here. I'm also going to then shift and talk a little bit about incentives that the Medicare program has been able to apply in provider payment generally and hospital payment specifically in a way that haven't historically been applied in the private sector, and talk a little bit about why it is incumbent upon Medicare as a public payer to apply this sort of financial pressure. And then I'll take 30 seconds at the end of my presentation and talk about the impacts over time of the Medicare program applying financial pressure in the way that it has. And implicit in my comments here are the notion that, again, as a public payer financed by taxpayers and beneficiaries, it is indeed incumbent upon the Medicare program to apply financial pressure to providers. And we think that this is something that private payers, commercial payers should be doing more of. And it keys off something that Chapin said earlier, that providers' costs will basically follow their payments. The more you pay them, the more costs they will incur. And we don't think that's necessarily a good thing, and we believe that the commercial sector should be doing more to impose financial pressure on providers if the overall societal concern here is the unsustainability of cost growth in the healthcare sector as a whole. So a couple of commenters here today have mentioned MedPAC's payment update recommendations with respect to hospitals. We use a standard framework in making our recommendations. We look at beneficiary access to care, provider access to capital, quality of care, and of course the infamous Medicare margin. By and large, all of our, or most of our indicators of Medicare payment adequacy for the hospital sector are good, with the exception of hospital margins, which, as Paul said, have been declining steadily over time and are currently at about -10, and we project a margin of about -11% for 2019. However, there is a subset of providers that we've determined to be relatively efficient. They are not in the worst performing third of hospitals on quality, and they're not in the highest cost third of hospitals. And so when we look at the subset of efficient providers, we see that their margin is more like -2%. And so their performance is better under Medicare than hospitals as a whole. And so we focus our assessment of Medicare payment adequacy on this subset. So again, these are providers that do relatively well on cost and quality measures, and their performance has to be consistent over a prior 3-year period when we make these determinations. The metrics that we use to determine efficiency are mortality rates, readmission rates, and standardized cost per case. When we compare efficient providers, efficient hospitals to others, we have a relatively small group, 14% in 2017. And again, this is using a fairly generous definition of efficiency. You're not in the highest third of costs. You're not in the lowest third of quality. So, we're getting about 14, 15% of the hospital population in the efficient group. But in that group, their performance is relatively good. Their mortality rate is substantially lower than the average hospitals. Readmissions is substantially lower, and their standardized costs are lower. So it is possible to achieve a relatively high level of efficiency for some hospitals, even under Medicare payment rates. However, as Paul mentioned, there is a concern about a declining trend in Medicare margin over time. Here you can see that the margin for all other hospitals is currently about -9, -10 in the last couple of years. Until 2015, the efficient hospital had been able to stay in the black under Medicare. They went negative last year for the first time at -1 and now are at -2. So MedPAC made a recommendation this year for the hospital update that would still apply financial pressure to all hospitals in the form of a lower across-the-board update, but would focus more money, and again, more dollars than warranted under current law, to the most efficient providers. I'm going to switch gears now and talk about incentives. And again, here the incentives are something that Medicare has been applying in a way that historically commercial payers have not, and the exemplar is the readmissions reduction program. Last year we did a comprehensive evaluation of the HRRP, and we determined it's been a success in getting hospitals to reduce their rate of readmissions without any concurrent increase in patient mortality. And their efforts have saved the Medicare program about $2 billion in the most recent year that we examined. So incentives are important. Providers do indeed respond to payment incentives. And again, it is incumbent upon Medicare as a public payer to provide these incentives. Medicare has done this throughout its fee-for-service administered pricing systems over the last decade or so. And here you can see the aggregate impacts of that spending, where you look at Medicare per capita cost growth over the last 10 years, represented by the dotted yellow line, and it's roughly half of corresponding premium growth for HMOs and PPOs in the commercial sector. So by applying this kind of financial pressure and the incentives to get providers to do what you want to do, you can indeed influence overall spending and cost trajectories. So with that, I'm done.
Great. So let me talk a little bit about public policy. So what are the policy implications, the policy questions that we're struggling with? I think the first is if we take some steps to rein in the prices that commercial health plans are paying to hospitals, will that result in hospitals becoming more efficient? Right? If you squeeze that the high price discriminated against payer and the prices they're paying, and you squeeze hospitals' revenues, are hospitals going to move in the desired direction on the production frontier? That's an open question, and I don't think we have a great sense of what happens when you tighten the spigot on a hospital's revenues, and what happens to their quality, and are they still doing the things we want them to do and returning patients to the community? I don't think we really know the answer to that, but that is at the top of my list of research questions to dig into. I think MedPAC's result on there are these efficient hospitals out there says it's not off the table that you can constrain revenues and hospitals can still perform good, provide high quality care. But the question is whether hospitals will naturally move in that direction if you constrain their revenues. The second policy question that comes to my mind is the ACA productivity adjustments. I love that we're on a panel where we're talking about the ACA and we're focusing on the productivity adjustments, because if you people focus on the coverage expansions in the ACA and on ACOs. If you look at where the money is in the ACA, it's all in the productivity adjustments. That paid for a huge chunk of the coverage expansions in the ACA. Okay, the question looking forward is it feasible for Medicare to continue to apply these productivity adjustments going forward? And that relates to the question of whether we're are hospitals at the efficient frontier? And if we keep cranking down their Medicare reimbursements, are they going to have to start throwing overboard activities that are really important clinically? I don't think we really know the answer to that. The trustees tell us that the Medicare Part A trust fund is going to go insolvent in a finite number of years, in the scarily near future. And at the same time, OACT is telling us that the productivity adjustments are unrealistic, that hospitals aren't going to be able to keep up, and the gap between private and Medicare payments is going to grow over time. How do we square those two facts? If Medicare is going broke and Medicare needs to pay more to keep up with hospital costs, there's only one solution to that, which is massive tax increases to pay more into the Medicare program so they can pay hospitals more. I don't think that's really on the table. And I want to know, is it really true that it's unrealistic, impossible for hospitals to crank up their productivity growth to keep up with the productivity adjustments? So that was the ACA policy question. Do we maintain the productivity adjustments? I also want to point out that there's a legal case proceeding through the courts challenging the Affordable Care Act, and it's possible that the courts could determine that the entire Affordable Care Act should be struck down. The productivity adjustments would go away as part of that. That's kind of making a policy decision to cancel the productivity adjustments, but by default, kind of stumbling into it out of kind of a broader anti-Obamacare motivation. I think the biggest public policy question in my mind, though, is when we're talking about Medicare for all or public options, what's the right level for those plans to be paying hospitals and other providers? And is it more like commercial plans and what they're paying today? Is it more like what Medicare pays today, or is it somewhere in between? I also want to put a peg in the question of when you're talking about Medicare for all, and when you're talking about public options, maybe state-run public options or a federal public option, how are they setting their provider payment rates? And are they setting their provider payment rates the way commercial payers do today, or are they setting it the way Medicare does today? And this is a governance issue. In the Medicare Part A trust fund, we have a fixed budget paid by taxes, very clear, transparent, obvious taxes. Every payroll stub you get, it shows how much is going into the Part A trust fund. And we have MedPAC, we have CBO, keeping a track on exactly how Medicare is paying. And that governance structure has led to the Medicare Part A program being pretty aggressive in constraining growth in payment rates. And my question, I don't see it addressed or even really nibbled at when people are talking about Medicare for all and about these public options is, do we want Medicare for all that people are talking about, and these public option plans, do we want it to be setting prices the way the Part A trust fund does, which is pretty aggressive on putting the brakes on price growth and revenue growth? Or do we want it to be more freewheeling like in the commercial sector? And I think that's the long run question about how these Medicare for all and public option plans would play out. And I think a lot of it comes back to this question of, are hospitals at the efficient frontier? And my big picture take is no, clearly not in the U.S. And I don't find it satisfying to look at historical trends within the U.S. because we've had just one set of public policies in place. What I find really informative is comparing hospitals in the U.S. with hospitals in other countries. There you get a richer set of information about the production possibility frontier. And Jerry Anderson did a beautiful study comparing how much Johns Hopkins Hospital gets paid for a heart valve replacement versus Keio University Hospital. In Japan, Johns Hopkins gets $55,000. Keio University gets $40,000. How do they get by with that much less in revenue? And can the hospitals in the U.S. Follow suit? And how do we help them get there closer to that production frontier?
Thank you.
Well, I'm not going to use my slides for a couple of reasons. First of all, Paul, I want to thank you for letting me come. I look back, and this is one of the most productive discussions I've been part of in a very long time. I really want to thank all the speakers who've come before me. So that's the positive statement. The negative statements, I realize I'm in Washington now. I have tremendous respect for those of you who work in Washington, and particularly MedPAC, having chaired ProPAC for 13 years. But I have to tell you, you are increasingly talking about a world that doesn't exist from the world I see. I totally believe, and you're absolutely correct, if you want to constrain spending, you have to constrain spending. So the ultimate model that MedPAC and others say, we need to constrain the amount of money that Medicare is paying to constrain the spending on the part of the hospitals. I hate to tell you, hospitals now are increasingly thinking as Medicare being irrelevant. If you have two people walking into and one's giving you $1 and one's giving you $3 and is willing to give you $4, who are you going to listen to? Why should you worry? And you're beginning to understand the world that's out there. If you want to really look at the world, look at the physician side. Now, I'm one of the few people in this audience who depends upon Medicare for my health care. I've lost 3 primary care physicians in 4 years. The primary care physicians that are left are increasingly giving me 6 minutes, 7 minutes. I think concierge medicine is illegal, immoral, and fattening, and I joined it because I needed it. I had no choice. My lifestyle I can't wait for them to give me 6 months appointment. So you got it, Louise, you got it absolutely right. Those three choices are exactly what is happening. Right now, on the hospital side, Medicare is a free rider. I have no idea what kind of health care the hospitals would actually produce if all the money they got. Your comment, Chapin, is absolutely correct. If only they got Medicare payments for everybody, I have no idea what kind of health care they would provide, but I don't want to get sick. And don't tell me what's going on in Europe. We're not Europe. We've had 50 years of this thing. So we need to, you guys are so smart. You need to be thinking about this. And with all due respect, can we just bury cost shifting as a term? You've done us a service by creating it. It's so out of sync right now with what's going on. Call it what you want, price discrimination and stuff like that. We have a delivery system out there that is totally different than it was even in 2000. With that said, let me just end by what we're doing in Massachusetts. I think increasingly we cannot have a payment system where basically you're running three spigots that have nothing to do with each other: Medicaid, Medicare, and private. We need a system that takes some degree of control over all the spigots if we want to bring about productivity growth, if we want to decide what's a fair thing. How we do it, and that's why I was a Fed. I didn't even know we had states. When I was in Washington, I thought that people who worked at states were like people on training wheels. And if you were really good, you were in Washington. I hate to tell you, more and more of the pressure is now at the state level. I think what we're doing in Massachusetts, we made a decision, they made a decision back in 2012. From now on, we're going to be concerned about total spending. We're not concerned only about Medicaid spending. And in fact, we're trying to do it. 6 states now in the last year or two are moving to total payment systems. Oregon passed it last week. Delaware, New Mexico, Washington State, you're increasingly moving to the recognition that if you're going to do anything in the public sector, you have to be concerned about the total flow of dollars going into the system. And so you're absolutely right in terms, if you want to control spending, you have to control spending. Medicare no longer has much of an impact because in fact it is squeezed so low and you've allowed the other side. So all I would ask you, those of you, because you guys are doing wonderful work, you need to take a much harder look at the current environment and change the models. It's not that everything you said made sense, but it's the reality of, and Chapin of all, he just, and the RAND people just did a wonderful study, what's going on, whether it's Indiana or on average, 240% private over Medicare. So come on, the average is 180%. As I said, the healthcare industry increasingly is dancing to the tune of where the dollars are. And it makes, so to talk about somehow Medicare payment policy is going to impact the productivity of the health sector is a joke, unless we get them all playing from the same set of song sheets. So that's what, and Medicare, and what we're doing in Massachusetts actually is working. So I'm not going to, we've already talked about this thing. I mean, when you even look at the ACO savings, the Medicare rightly saying, I'm not seeing those savings. The ACO people keep, well, if you redefine it, what it would have been, I'm on your side. I think Medicare isn't seeing the kind of savings. So, we're just beginning in Massachusetts. We don't have rate regulation. We have benchmarks. We're trying to jawbone the private sector, both the insurers and the hospitals, to live within a growth rate consistent with our income. And in fact, it's working. And if you look, and I've given a couple of, and I'll just leave with this last slide. If you look at what's going on in Massachusetts, we went from being not only the most expensive place in the planet, but also the fastest growth rate. We're now the 4th lowest growth rate in terms of total spending in the United States. And as I said, we're doing it without tough rate regulation. We are trying to use antitrust. We are squeezing, and we have some pretty powerful providers. Come up to Massachusetts sometime, and you'll see how powerful they are. But in fact, we're making it work. I'm not sure I completely understand why it's working, and I would welcome some of you to come and help us figure that out. But the reality is we are looking at total. Medicare is part of that, but Medicare cannot do it alone. And to keep talking about somehow you're making the system more efficient by Medicare rates, I'm sorry. That's not the reality out there. They're not listening to you. They don't need you. Now, the people that do need you, when you go to safety net hospitals and they're on Medicare, they need you a lot, and they're furious because they're getting squeezed. Now, go to the Mass General sometime and ask them how much they really, really worry about Medicare, given the fact that they can essentially force the private sector to pay any rates they want. So with that, I'll stop, and I welcome a thorough discussion. And as I said, I couldn't be more pleased to be here. Thank you, Paul.
Okay. So thank you, all of you. We covered so much territory in that it's a little hard to know where to start. But I'm going to start maybe with some of the similarities between what Chapin was talking about and what Stuart was talking about, which is if you're thinking about a Medicare for all, because that's sort of what you're doing in Massachusetts, at what rate do you set it? And then, a lot of questions already came up before about how are we relative to Europe. And I think a question I want to ask here is when we think about differences and what we think about something like Medicare for all, is the expectation, do you think, that we could really improve productivity, or that we are going to sit on things like wages and compensation, which isn't productivity, it's just a distribution, which I think, it's not 100% clear what the differences are between Europe and the United States, but certainly payment is part of it. So what would each of you actually think about how would you set a Medicare for all kind of price, and what would be the considerations? I'm just going to, why don't you start?
Right. How would you set the price? I don't know what the right price is, but I know that in our current system we have agencies, organizations that are helping guide us. And OACT is one, MedPAC is another, CBO is another, CMS is another, and these organizations are putting the cards on the table and helping inform a healthy policy debate. And in Congress, they're roughly trading off tax increases versus provider payment cuts. And for a long time, they were going with the tax increases. Lately, it's been provider rate cuts. And I don't know if the rates they've landed on are the right ones, but it's a healthy policy-making environment. Contrast that with employer-sponsored insurance, where employers, the HR, the human resources folks, generally don't understand healthcare. They're relying on brokers. The brokers are in bed with the carriers. The carriers are in bed with the hospitals. And nobody knows whether they're paying a fair price. They don't understand how to measure quality. They don't know how to get better quality. That is not a healthy policymaking environment in general. I mean, there are glimmers of useful information being generated and transmitted, but the governance structures around the Medicare program are very healthy, and I think those governance structures, we need to have them in mind when we talk about Medicare for all and public options.
Well, we have established what we think is the right way to do it, and I agree with it, which is over time start squeezing slowly. And as I said, we've set benchmarks based on what we consider to be our long-term growth in income. And originally it was at 3.6%. It's now down to 3.1%. And in fact, the system is living. Now, when I was in Washington, I was the ultimate regulator in 1971. I'm the only person that ever regulated rates, full rates, had rate regulation at the federal level in peacetime. But I was 35 years old, and I had never been to the hospital since I was born. I didn't give a damn about the healthcare system. I am now falling apart. I care a lot more about the healthcare system than I used to. And the idea that somehow we're going to wake up tomorrow morning, that Medicare for all is a joke, because they never talk about what Chapin said. If all of a sudden we went to Medicare for all and all those private rates went to Medicare rates, we're talking about taking between $500 billion and $750 billion out of the American healthcare system. I have no idea what the healthcare system would do with that kind of, no amount of productivity would ever come close. So I think what we're doing in Massachusetts, there is no one right answer to your question. We're trying to slow the growth over time, because I firmly agree with the MedPAC rule is you've got to, forget about waste, and if you want to make the system spend less, you have to give it less revenue and force it to deal with it. But as I said, my criticism, and it's not a criticism of you, you don't have that authority. So that's my view, is we need to squeeze on the system. There's no one right number. We've picked the growth in our income, and we're slowing faster than the rest of the country.
Anybody else want? Do you want to go ahead?
I
can't believe you want to talk about this.
I actually am not going to answer your question, but I am going to respond to Stuart. Is just the notion that Medicare is becoming largely irrelevant. When Medicare is 4 or 5 of every $10, I think we still get a fair amount of intention, placed on what the Medicare policy. I don't claim to be a regulator, but I know a lot of regulators in my organization. And so the notion that, and I probably underestimated or underemphasized the notion of what's happening with respect to quality incentives and the demonstrations that are truly trying to reshape the incentives around where those revenues are coming from these organizations, from just just from the service base to the quality base, and so to the extent that there is at least some degree of transformation that's occurring, it is starting at the CMS level, as such that we can actually have this discussion over what is the right level of payments, and how can we align those incentives to exactly what we are trying to get out of our system. And so at least those conversations are happening, probably not to the speed and perhaps success that others might want to see in terms of actually lowering the levels of healthcare, but clearly the direction has shifted and is moving in that direction. So.
Do you want to? Sure.
Okay, for the record, I am not going to talk about Medicare for all, but I do want to address a couple of comments from Stuart and from Chapin. First, I do agree completely that to do something about cost growth in this country is going to require a concerted effort across all payers that simply does not exist. And from my perspective, Title 18 is the sandbox that I have to play in. So that's what I do. But I do not disagree with you that it is going to require effort across Medicare, Medicaid, commercial, and as I said in my comments, Medicare has been attempting to apply fiscal pressure in the form of reduced updates, in the form of value incentive programs, and is trying to move that needle. And in imposing that level of fiscal discipline or fiscal pressure, it has widened the gap between financial performance under Medicare and financial performance on the private side. But I think that gap is somewhat illusory in that it reflects a growing cost structure on the provider side that's being fed by extremely generous payments on the commercial side. And so I wouldn't say that it is beyond the realm of possibility for providers to control their costs in a more substantial way than they've done in the past, given the right incentives. And one of the bits of evidence that I would point to in making that assessment is in conjunction with the efficient provider analysis that MedPAC has done over the years. We've also looked at hospitals that are under fiscal pressure. And we define these as a subset of hospitals that have very low private sector margins, they have very low net worth. And when we compare those hospitals to another set that are not under financial pressure, we see that the financial pressure hospitals have lower per unit costs and lower cost growth over time. So
Couldn't agree more. But those are the you're putting pressure, some sense, on the wrong hospitals. I mean, in a public policy sense, you're putting them on the safety net. So we all agree. I think.
Sort of. I have a question. So I want to bring it back to the hospital productivity stuff and the stuff that John did, which is I see this tension between this idea that clearly we want to reduce spending and reduce costs, and that putting pressure on hospital reduces costs. May well be that the hospitals that are under financial pressure aren't doing some of the things that lead to some of the outcomes that John's picking up. And so, and you know, these can be quite difficult and subtle to measure, right? Like getting risk adjustment right is really hard, and sort of knowing the timing of when a cost squeeze might show up in mortality, because it may not be right away. So is there a tension there?
Yes.
Between
That's great. I mean, when you look at our safety net hospitals, they're not bringing the technology on board. You go into those hospitals, they're older and they're seedier and they're cutting costs. But I love the study that you raised, showing that if you really do a good job, we are seeing improvements in productivity, maybe not as much as we could. But go look into the middle of those hospitals, the ones that you call the ones under fiscal pressure, and compare them. And where do you want to go to get your health care? I'm sorry. I'm not going there.
David, did you want to?
Yeah, there's a really nice study by Yu-Chu Shen and Vivian Wu on the long-term mortality impacts of Medicare rate reductions, and they raise a flag that if you start cranking down on Medicare reimbursement rates, you may see negative impacts on healthcare outcomes. Now, I don't have a good sense of the totality of the literature and whether that finding is backed up and whether it holds up over time. But in my mind, the path to go is first address the egregious overpayment by commercial payers in many contexts. At the same time, push hospitals to improve quality actively. It's a separate dimension, but if all we're doing is constraining revenues, you may not get, the desired outcome. What we want to be doing is pushing simultaneously down on the revenues and up on the quality, and those are two separate undertakings. But you don't want to just be focusing on the revenue side. You want to be actively pushing them to improve quality through things like the readmission reduction program, unnecessary C-sections, and so on.
So a lot more of a shift in the way we pay towards performance-based, or do we actually know? So we have examples when we know they work, but how much confidence do we have that we could do a lot more by having sort of marginal incentives,
I think you can get a lot of juice out of measuring outcomes, comparing providers, benchmarking, and relying on their professionalism, their nonprofit status, their community benefit orientation to want to do better. And it always makes me a little nervous when we say, okay, we have this professional cadre of healthcare providers, and the only way they're going to do better is if we pay them. That's not necessarily true, but just measuring, figuring out what makes a difference in healthcare quality and outcomes, measuring, reporting, jawboning, pushing on hospitals, taking, using their professional orientation and the fact that they genuinely do want to do better.
Okay, last question from me, and then I'll go to the audience. And this is going to go back to where we sort of start, which is, so when we think about margins, do we care about the overall margin? Do we care about the Medicare margin? Do we care about the marginal cost of the Medicare patient? Like, what is it that we should be most worried about? And when would you say, oh, here's a real signal that we better change policy and change course on this productivity adjustment?
Well, what do you want to do? I mean, there's no question that in the short run, on the hospital side, and MedPAC has said it several times, that hospital still pays a hospital to take on a Medicare patient. But you know what? If we keep doing what we're doing, you're going to see hospitals begin to behave like physicians. I don't know where it is. You're going to see some hospitals, become much more restrictive. Now, as I said, I hope that never happens. I think we made a commitment to the seniors that that should never happen. And I appreciate the fact that MedPAC is now recommending an increase because it's getting nervous, as it should. But we don't know where that rate is. As I said, I think the physician market is a better indicator of the problem that's already being created, particularly at the primary care level.
Can I ask you to say a little bit more about that? Because a couple of things. When MedPAC assesses the adequacy of Medicare payments to hospitals, margin is one thing that we look at, but we also look, as I said, at access to care, supply of providers, access to capital, and all of those indicators run positive, even in light of the financial margin. Let me just say one other thing. When you said that if we continue to apply pressure on hospitals, we start to see hospitals morph into more of the physician response. MedPAC also does an annual survey of beneficiaries and specifically measures their access to care, their timeliness of getting an appointment, their ability to find a new physician when they are looking for one, and consistently over time, the performance of Medicare with respect to its beneficiaries accessing physician care is consistently better than the commercially insured population, age 50 to 64, even though Medicare is paying physicians 75 cents on the dollar relative to average commercial rates. So could you talk a little bit
Yes, I
more?
would definitely. I would suggest that we live in a very world where we have many populations. So if you go into our major upper middle class cities, Washington, New York, Boston, Miami, Los Angeles, San Francisco, and go to the populations that I would call the upper middle class and above, and ask them how easy it is for them to get access to primary care without going to concierge, you'll see a very different story than the story. Sure, I speak to thousands, not hundreds, thousands of physicians and patients, and increasingly to seniors. And over the last 5 years, each time I do that, I said, how many of you are having trouble getting primary care? And 5 years ago, 1 or 2 hands go up. Now I'm seeing still maybe 10, 20%. It's not the whole population. You wander around this city. You're all, federal employees, particularly husbands and wives working, or the upper middle class. I'm telling you what happened to me, and I'm a pretty important person in Massachusetts. I lost 3 primary care physicians, and I said I give up. And so I suggest you need to take another hard look at that, because I think you're trying to do the right thing, and on average, it's still not a problem. But if you take subsets of the population that have the means to say, I don't need to deal with this anymore. I want better care. I want more access to care. And they're willing to pay for it. And that's what I finally did.
So I think the question that's been alluded to in just about everyone's talk today is at what point and how does it manifest this divergence between private and commercial and Medicare payment rates? At what point does that become a breaking point? And what does that breaking point look like? And what are the ramifications? And what is anybody going to do about it? And I think all of those are largely unknown. I think it's all things that we are all concerned about and all things that we need to be following extremely closely, because at some point, privates aren't going to pay more. The Medicare payment rules are not going to change, and the current dynamic is not going to be able to sustain. What's going to happen? I don't think any of us know.
Terrific. Okay, let's open to the audience. Wait for the mic. Stuart, you want to? You get your choice. So say who you are again, even though you are.
Hi, just 2 points. One is when you use the term pressure, I have difficulty relating to the term pressure when it comes to payments for health care in a country where we spend $3 trillion a year on health care, 40% more than any other country in the world. So I wouldn't call it pressure. I would maybe say we should look at how we spend that $3 trillion and figure out a better way to spend it to get the health care we want. And that includes looking at things across payer. And if while we're on that topic of relating one payer to another, you don't need to go to Massachusetts to see that. You can go up the street to the state of Maryland, where I've worked with the folks there. We have all payer rate setting. They're not the same rates for every payer, but they're pretty close. And one of the criticisms that folks in Maryland get is that, especially from CMS, is that Maryland, the last number I heard was Maryland spends $2 billion a year more in Medicare spending than they would under the national system. But private payers, they pay 108% of costs, is the number I heard, compared to 145, 150, 180% of costs in the rest of the country. So it does seem to be working. The one drawback is that the Maryland regulatory system is focused on hospitals, and now we've put hospitals on a global budget that includes all healthcare spending in the state. But we only have regulatory authority on hospitals, so we've got to figure out a way to kind of extend that to the rest of the healthcare system.
Buzz? Right over there. Right there. Just tell us who you are, please.
Hi, I'm Caroline Steinberg, James Creek Consulting. I was at the AHA at the time that the ACA was negotiated. And the first thing I wanted to say that there was not an expectation on the part of hospitals that they were going to improve their productivity. The expectation was that they were going to, that this was going to be paid for by increased coverage. And of course, that only really works in the first 10-year in the budget window, and nobody honestly was really looking outside the budget window. But then also, I think it's also important to note that the productivity cuts really didn't happen in the way that CBO estimated. First of all, productivity was much lower. And then also the forecast error went in the direction of hospitals, I think all the years so far except for one, so that hospitals never got a rate cut because of the ACA. And CMS does not adjust for the forecast error. So this divergence in margins is not because Medicare was excessively constraining costs, because it didn't really happen. It was because something was going on, that costs were growing, one might say indiscriminately over this period. And it's also evidence in general, I agree with Stu that Medicare is not influencing hospitals. I mean, what we have is a situation where there's significant consolidation for everybody. Employers have no leverage. Medicare doesn't matter because they can make that up on the private sector. And I think when you try to look at things at a very global level, it doesn't really get you anywhere. I think what you really have to look is like the study that Rand did, where they looked at the differences in prices from market to market, and even within market, there are huge difference. Like if I look at I actually have access through my health insurer to the prices that I would pay, and I can look across the hospitals. And I can see that, I live in Northern Virginia, very, very consolidated. I have to drive into DC to get a better price, and I'm sure that that hospital knows it. So, I mean, we got to do something about the market, and it's not. I mean, Medicare can do whatever it wants, but until we address the pricing power and the pricing differentials in the private sector, we're not going to get anywhere.
Yeah. So this question of whether Medicare matters hugely. Let's. In terms of volume of services, Medicare is maybe 40+% of the output that hospitals produce. Medicaid's maybe 15%, and then commercial uninsured marketplace, workers' comp, that's the remainder. So Medicare plus Medicaid are paying for most of what hospitals do in the aggregate, and they're kind of a stable ship, but the kind of boring and stingy, right? The commercial side is where, all the exciting, high prices, and that's where all the profits come from. And So in our study, we found commercial is paying 240% of Medicare. If the Medicare margin's minus 10%, so hospitals' costs are maybe 110% of Medicare. In commercial plans, they're paying 240% of Medicare. Most of commercial payments to hospitals are profits, right? So those profits are going to light up the eyes of the hospital executives and lead them to open more, freestanding ERs in suburban, privately insured neighborhoods, and expand their service line offerings that are tailored to the privately insured population. But Medicare and Medicaid together are still paying for most of what hospitals do, and Medicare matters. On the question, which one's going to break Medicare? Is Medicare going to come up, or is commercial going to come down? I think it comes back to Stu's point. Our healthcare system is not under-resourced. That's an understatement, right? The system is not under-resourced, and who's going to break? I think commercial plans are going to break. They're going to be the ones to break.
I disagree with you. I really, and you've done some really good research. So what I would suggest you do, rather than make a global statement like that, go to Fort Wayne, go into the middle of Indiana, go into those hospitals and say to them, how many of you are really aggressively doing an ACO where 80 to 90% of your patients are on fee-for-service? I talk to these hospitals all the time. They say, well, wait, you know what, mañana, I'll do it tomorrow. When the private sector go, I don't know what you're talking about. No question. Of course, Medicare. I was just pushing your buttons. but you're increasingly less relevant under Medicare. Is that a more common statement? This idea of 40% and this idea that all of the private money is profits doesn't make any sense. That's what's funding a lot of this technology, the higher, if you call all of that profits. So the idea that, sure, Medicare is important. It's critically important. But what we did with respect to the DRGs, which is we mandatory change the payment system. None of this you keep talking about what you were saying. The idea that you only play in the ACO is if you're going to win. It's not mandatory. You look at your own numbers. It's in rounding errors in terms of the savings. So unless and until we get a combined activity, and it doesn't have to be the same rates like Maryland. It could be a structurally related. Second, we're playing from the same set of incentives. And make it mandatory. This idea that you only play if you win, and the ACOs are trembling, the idea that they might take risk, oh my God. So I think you need I don't disagree with you, Chapin. Of course Medicare is important, but it's less important than it was 10 years ago.
So why don't we measure for value, price, and reward value? And by value, I mean outcomes achieved relative to spending. If you want to know what a fair price is, Uwe Reinhardt used to say, we know this, I'm sure, the finest healthcare in the world costs twice as much as the finest healthcare in the world. And why is that? Because price does not equate with value. Macro MIPS, cost, quality, separate. They're not measured simultaneously. MedPAC doesn't study this. I mean, we're talking about productivity. We're talking about sustainability. We don't talk about measuring for value. And I could tell you, since you mentioned Alexander's bill, surprise building, Section 303, I'll point you to the exact phrase, the nonprofit, non-governmental agency that's supposed to make transparent data, commercial claims data, quality, cost, and guess what they added between the draft and the final version? Value. Outcomes achieved. iCHOMS has been working on this out of Boston. Michael Porter out of Harvard for a dozen years. So if we're going to get at productivity, we have to start thinking seriously about measuring for value. So my question, if I could pose it, is why are we ignoring value?
So I'm just going to say, so I think that's John's paper on productivity was all about thinking about value. And so that whole trying to measure productivity in those ways where I saw prices were coming down was because of the value that people placed on what they got. Now the question is, which you brought up a little bit, is how is the way to get more value to pay for it, or is the way to get it to measure it, to compare, to jawbone? How much more should would a system that really was just paying for value more than what we have now make a huge amount of difference? I don't know, does anybody have a view or a response?
I always get apprehensive when we're talking about value, because the value based to whom, based on what measure. And that opens up a very large debate. And so when we are trying to estimate what is the cost of a particular provision, without actually getting detailed specifications as to what exactly are you measuring and what are the different incentives associated with it, value can often be in the eye of the beholder.
Anybody else? Questions? Go ahead. Over here, up front. Just tell us who you are, please.
Hi, my name's Lewis. Quick question. You had mentioned that there were about 15% of hospitals were considered efficient, which had a very relatively low or less negative margin. I guess my question is, was there anything specific about that tied those hospitals together, whether a geographic distribution, socioeconomic settings, academic versus community?
The only fact, and I'm sorry, the only fact that comes to mind in terms of characterizing our relatively efficient group is that for-profits are somewhat underrepresented in the efficient group. Other than that, Jeff, I don't know if you want to...
Yeah, that's about the only one. The other one is they tend to be larger. Oh, sure.
Thank you.
They tend to be larger, and part of that is the quality metrics, especially mortality, tends to be a little better at larger hospitals. The other factor is we require some stability of performance over a number of years, and it's just harder for smaller hospitals to get that stability of performance.
So I had a question about that before. I'm going to follow up, which is, so if you're saying the payment policy should be based on this efficient hospital and, a small hospital can't get there, then are you not just penalizing the patients who live in areas where hospitals, maybe it's a small town, or maybe it's just not going to change overnight? Why would you base the payment on that unless you thought your payment was going to drive the efficiency to that level?
At some point, we're going to have to make a tough decision on what you said, which is what's the product that we're buying. And things like mortality and even morbidity become only part of the equation. I've been in a hospital several times, and I wanted good food. I wanted easy. Listen, if I go to the Ritz-Carlton, I want my hospital to look like the Ritz-Carlton. I went to hospitals in other countries to look around. I don't want to go there because I view quality in a very different sense. And not me. I think most patients do. And so we need so when we talk about buying, the reason why I like the slides, when we talk about buying a product that is different, and if all of a sudden we didn't have that product and it began to look like the products in Europe, even though the mortality rates don't change. Hey, listen, I grew up with MASH. They saved a lot of people. I wouldn't want to get my health care the way the MASH units were set up. So I do think that when you talk about productivity, you have to talk about it in the context of and that's the reason why I like the new slides, which have those positive statements when you take a broader view. And I said we even need to take a broader view.
Oh, great. Did you want to respond, or? No, you don't have to. Anybody else? In the back there. Okay, tell us who you are and where you're from.
Lou Gagliano, Coalition to Transform Advanced Care. If we've learned anything in healthcare in this system, it is that incentives and pricing does make a difference. And I go back to the implication or the application of the macro rules, both on, as you said, readmissions, and as importantly, infection rates in hospitals. And if you look at what's happened because of those incentives or disincentives in the case of the clawbacks that occur, it did change how hospitals operated. And when those rules got popped, they had to react to, how do I do surgery in a more effective way so that post-infection rates don't occur? So I think that that is one issue. The other issue is I think CMS and Medicare has got to change its philosophy on pricing. And the question is, how do we build quality and measurements in it, not just looking at how to wrench down pricing, because that results in nothing, as you've learned in Massachusetts. So we need to be more global in terms of embracing concepts of how does pricing create the right incentives to drive care in hospitals that does result in better patient care and outcomes, because better patient care and outcomes drives down cost.
Wait, you want to go ahead? All right.
One quick thing on pricing and incentives. With commercial payers paying 240% of Medicare, it's a huge incentive for hospitals just to do more of whatever the privately insured patients get, and give an EKG to every patient who comes in the ER. Build new freestanding ERs in these suburban privately insured areas, and there's huge attention and research and thought going into Medicare payment policy and steering providers in the right direction. On the commercial side, it's not, I mean, there's ACO activity and pay for performance and so on. There's also just gross over reimbursement of anything a hospital does to a privately insured patient. And that skews incentives not in the way you want. So I think that, Medicare can do more to boost more of what we want, but I think it's also important just to kind of ease off the profit incentives to do more of anything to a privately insured patient.
Okay, well, we are out of time. Please help join me in thanking our panel.
Thanks for watching. Be sure to like and subscribe for more videos from Brookings.